So it's my great pleasure to introduce Dr. Mitch Cats, who's been an amazing leader and spark for all the work that many of us in the room are doing. So I think we're all familiar with who he is, and so I won't say much about him except that for anyone who didn't know, he does direct the Department of Health Services here in Los Angeles County. He came here in 2011 as a primary care physician and is very focused on improving the delivery system in Los Angeles County and connecting that system to community partners. Introducing medical homes and improving quality implementation and continually transforming that system to produce the outcomes that it can and should. So he's been a wonderful spark, and we wanted to launch the day by having him give us some introductory remarks about the application of DII Science to the needs of the Department of Health Services. So welcome, Dr. Katz.
No. Well, making a difference is always good. But actually, I wasn't planning to do this such a formal talk. The reason I'm so happy to be here, well, first I have to read you because I thought this was a wonderful typo. If you look in the program, it says that I oversee a $3.5 million annual budget with 21,000 employees, which suggests I don't pay very well. So no wonder everybody's so unhappy. You know, I've been going to work and thinking this is such great work. Why is everybody so unhappy? And now I understand. I think that's means I pay people like $125 a year. We have a $3.5 billion budget, so there's a lot more zeros. My own work, originally when I was in training, all I wanted to be was an academic primary care doctor. I wanted to take care of my patients, and I wanted to do research on how to better take care of my patients. And that all seemed right, except that my own experience as I got deeper and deeper into doing research was that it wasn't really having much of an impact on the people that I most cared about. So it was it was the middle of the AIDS epidemic and the horrible dark years and highest rates of death in San Francisco due to AIDS, and I was working as doing clinical epi, which is how I was trained, and I suddenly turned around and realized, gee, my research is chronicling the rate at which people are dying, and that's not helping anybody. I mean, the research itself was doing very well. It was funded, it was published, but it didn't make me feel very good. And at the same time, I had increasing roles of responsibility in the health department, and so I kept doing various interventions. So I did needle exchange at a time when needle exchange was illegal. I did a lot of housing programs that were focused on something that came out of implementation science, which was the housing first model, the idea that rather than trying to prepare people for housing, which was basically a hopeless cause, right? The paradigm that I was trained under in the case of housing was, okay, well, first you connect the person to medical care, and then their primary care doctor connects them to substance treatment, and don't even send them to a mental health clinician because till you treat their substance abuse, you can't evaluate them for depression or thought disorder. So mental health after they get their sobriety, and then if they've achieved all that, then try them in a transitional housing like Shelter Plus, and if they do okay in what is a much more difficult environment for most people, that is congregate living, than individual units, then you can house them. And so this sort of continuum of care turned out to almost never work, because who gets sober living under the freeway, right? It's hard enough to get sober when you really want to and everybody is helping you, let alone while you're living under the freeway. So I view that as an implementation science, right? Somebody came along, it wasn't me, and turned this paradigm on its head and said, gee, the way that we've been doing this doesn't really seem to be working. And so we started, as we housed people, we started chronicling our experience. And what our experience showed was that people who we put into housing started using less, right? Because they had something that was meaningful, they had something that they wanted to protect, and they weren't out on the street all the time. We found that people who were mentally ill, housing them didn't cure their mental illness. Of course it didn't. But they certainly, especially people who tended to be paranoid, were much better, right? Because they weren't living in environments which really increase fear, let alone paranoia, right? So all of a sudden, people were using less, and people were, hearing fewer voices and were doing better. We found that people reunified with their families, right? And you think about, again, housing and why that might happen. People reunified with their families because when you're a middle-aged man living under the freeway, how do you call your daughter to tell her to come visit you, or that you might like to see her? You're gonna ask her to come and meet you under the freeway? You're going to show her, what your life is like? No, right? You're just going to, do her what you feel at that moment is the best favor by not contacting her. Now we house you, and you're in a respectable place, and you're living a life that looks like other people. Now you call her. Now she comes to visit. Now you've made a family more whole again. And so basically a idea then became implemented across the board and then was documented in the research, which is one of the themes that I very much support about translational science, and I see buried in the abstract. The true traditional, what I see as science model, was always very important to that model to prove things ahead of their implementation. And sometimes, in my experience, that is not the most efficient thing. Sometimes, as in the housing first model, what is more effective is to implement something, but implement it in a way that you can evaluate whether or not it works. So it's neither extreme. It's not the, this is a good idea because I say it's a good idea, and people must be doing well because I came up with it. So it's not a sort of a science, this is what common sense tells us. But nor is it we're going to do 3 to 5 years of study and before we implement it. Because my experience is that often the implementation actually never happens. And that can be for a variety of reasons, including that the intervention works, but people don't want the intervention. I mean, it was, look at a very interesting, to me, example of implementation science challenges. Cardiac rehab has a very large body of data. That randomized controlled trials, you take people who've had heart attacks, you send them to cardiac rehab, studied in randomized trials, people who go to rehab do better. It's not used very much in this country. It's proven, it works, and I'd say in cardiology, we put in a lot of stents and treat people with a lot of drugs with much less evidence, but that happens. It somehow better fits our medical model than expecting that the best response to somebody's heart attack would be to help them with a graded exercise and help them to have a better diet, right? So the challenge to all of us is how do we, as implementation science people, how do we, even when there is good research, how do we figure out how to translate that research into practice? How do we make things that we know work move into practice? One of the things that made me happy about looking at the abstracts for today is that you actually see the impact of the overuse movement. There's one on choose wisely. There's another one using messages embedded into electronic health records to decrease unnecessary scanning. I mention this one because it is clearly a failure of the traditional research mode to look at overuse that exists in our healthcare system. But it is something that implementation science is looking at. And it has tremendous power for a couple of reasons. One is that when you reduce, as the presentation today later on will show you, when you reduce unnecessary radiologic screening, which can be done, save people from radiation, you save them from future interventions that may be done because the X-ray showed something that was incidentally wrong but is of no significance, but everybody feels, oh, well, I have to, stick a needle in that cyst because now that I know that cyst exists, how can I be sure that it's really okay? But maybe more importantly, in a system like mine, where I have a finite budget, it is bigger than the 3.5 million alluded here, but it's finite nonetheless. So from a mission point of view, if we can eliminate the 30% of wasted care that we know exists, I mean, that's the documentation of the 30% of wasted care is very good. The science on how to remove it from care, all of us are working on it. But imagine, to connect my themes, what that would mean for housing, right? If I could remove 30% of the unnecessary care in the DHS system, if I could remove the unnecessary radiologic studies, the unnecessary laboratory tests, if I could take people off the drugs that are not helping them, I could do all of those things because we are, have a finite budget and because we're genuinely interested in how to use that money in the best way possible, right? We have no shareholders to make any money for. We don't need, to maintain the system. We want to promote health. Think about how many housing units that would be. We can house somebody directly off the street for $1,000 a month. That's what it costs us to take somebody who's chronically ill, has mental illness or substance abuse or physical illness or all three off the streets. Right? You don't actually have to decrease that many CT scans, laboratory tests, and unnecessary labs to make a difference. But that is one of the things that I think of as the gift that implementation science can do. Because it's not, the research has already demonstrated the unnecessary tests. The question is how to get them to stop, right? How to, again, to connect the theme, how do you get people into cardiac rehab, which we know works, and how do you stop the placement of stents for single vessel disease, which we know doesn't work but is being done, right? So how do we as a group really focus on the mission that matters to us? So I appreciate all that all of you do and the field in general, because it helps me to do a much better job in DHS. It helps me. We want to be on cutting edge. We want to do things based on evidence. We don't want to just do it because we think that it's right. We want to know either based on prior research, or we want to evaluate as we make changes and be sure that we are doing the most good for the people that we have. So the research that you're working on today makes a huge difference, and I would really challenge all of us in the years to come. This is a new science. This is a path that can bring us much more gains than I think anyone imagines by taking proven things or evaluating good ideas and showing how they can make a huge difference. So thank you all so much.